Lighthouse Lab Services. We're going to be talking today about the question on everybody's mind: what does it look like to get back to the new normal and to get employees back in the workplace? What's the smartest way to do that? What are the things that we need to consider? What's everybody else doing? We're going to try to walk through some of the science, the different options that are available, what it means for you as an employer, what precautions you might want to take, and just give some advice. And also hear from you guys too on what you're seeing out there. So we'll have a few different polls that you can respond to. There's one up now that just tries to measure kind of what you guys are experiencing. And I know a lot of you are in the lab industry, so maybe you're seeing more or less testing. I'm not sure. But we'll go ahead and get started. Just as a point of introduction, Lighthouse Lab Services and Elite Diagnostics merged together a few months ago. So we were purchased by the same private equity backer and have combined forces. I think we're going to be bigger and offer a more comprehensive solution than ever. We've been able to combine both those teams and unleash the power of both of them, and the different strengths that both groups and companies have are being leveraged. But I just wanted to mention that because you may have seen this promoted under either brand. We are one company operating under two brands right now, with plans to get under one brand here by the end of the year. But there's a lot of integration that's happening behind the scenes, but we're really excited about our broader suite of services and offerings that we're bringing to the table. We're going to be rolling out a new product launch here soon, in the next month or so, that we're pretty excited about announcing. And then we have a few things we're going to talk about at the end of the presentation today that I think you'll like as well, that are new offerings for us. But for the most part, we wanted to focus this on what is happening out there in the market. You know, what are your options? What should you be considering when you look to get back to work? A little bit about us before we get started, just our credentials to speak on this matter. This is a representation of both companies put together. We've serviced over 1,000 lab clients, and we had them pull the paperwork we have in place, and people that have paid us over the last few years, over 1,000 labs nationwide. You see that map shows kind of where we serve most, and it tracks with the population for the most part. The coasts and down in Texas, pretty heavy for us. We've built over 100 labs from scratch. We have 140 plus labs that we manage or oversee right now, our MDs, PhDs, or we have under managed service accounts that we manage their day-to-day operations. I've built out our team of 8 PhD lab directors and 5 master's degree scientists that are making up our technical team. And some stats there on the bottom are in reference to sort of our reach or our web presence, our database of over 170,000 medical lab scientists, ASCP certified individuals with resumes categorized by location, skill type, what they're looking for in terms of a career in our database. Our newsletter, if you're not on it, the Lab Insider, goes out to 44,900 people. That's the Laboratorian, which goes out more to the scientist community. And our social media communities, if you haven't joined those, we have over 158,000 people with some really vibrant conversations happening in our Facebook group, which is called the Medical Lab Science MLS group, as well as our LinkedIn groups. We got about 12 LinkedIn groups categorized by specialty. So these are some of the things that we do. I mentioned that so you understand that we do know what we're talking about and have had to deal with a lot of these issues firsthand as we get COVID labs set up. I'm going to introduce Kara Long, who's going to talk to us a little bit about the science. She's one of our scientists and is also on the business side, and is one of those rare individuals that can translate the science to the average Joe. And she's going to tell us a little bit about COVID testing and the different options that are out there.
Thanks, Sean, for that intro. I'm going to jump right into really what Lighthouse role in the COVID-19 testing is right now. So what are we doing and how are we helping? So first, we're helping our clients with equipment procurement and validation. So we're really helping them, procure anything necessary to run the test. So think about the PCR instrumentation, ELISA instrumentation, and maybe even the ancillary equipment. A lot of this stuff is in short supply right now and sometimes even inaccessible because they're located in states that are still in lockdown. So we've used our vast network of equipment vendors to find certified pre-owned or new equipment that can be found in a number of the EUAs listed on the FDA'S website. So we're helping with that. In addition, we're helping validate these instruments. So we've validated 7 COVID labs to date so far, really helping them to operationalize the test in a timely manner. So we've been able to get those up and running in about 10 days once everything's procured. Additionally, we're helping provide an integrated lab network. So we're utilizing software to connect these labs to monitor their capacity and turnaround time in hopes to provide fail-safes to prevent supply chain disruption. So we have, in addition, we have proprietary software solutions that we can offer to these labs that can be launched in as little as 48 hours lead time. It's, of course, HIPAA compliant with the option to build the discrete data interfaces between both the instruments and also into your EMRs. Lastly, we offer staffing and recruiting. This is really one of the pillars of our business. So whether that be a need for a lab director to take your CLIA waived lab to moderate or high complexity, or a need for a phlebotomist or laboratory technologist, we have an unprecedented database, which John mentioned earlier, of qualified candidates ready to assist. So what's the state of COVID-19 testing in the U.S.? So I do want to preface this that this is the slide we used in a previous presentation, and the data is from early in May. So back in the early days of May, we were only running about 260,000 tests per day. I did check the COVID tracking project last night, and we are actually we've improved quite a bit in the past 20 days. We're running 400,000 tests daily right now. And while that's been an improvement, it's still not quite the 50% of the recommended target goal of just over 900,000 tests that we were looking for, which is really to test 10% of our population in a month. So the gap is still significant, and that's really because there's a lot of challenges sitting between us where we are today and where we need to be. So what are those current problems in testing? We're going to talk about them at a high level real quick. So everyone's really familiar probably with supply chain. It's been the biggest issue that we've talked about. The shortage of swabs and reagents has created really bottlenecks in our industry. So I was just actually on the phone yesterday with a vendor, and it's a 2 to 3 week lead time for the viral transport medium just to put the swabs in. That's, kind of comparable to the toilet paper crisis we're seeing. This is something we've never had a problem acquiring before, but, the lead time has been significant, which is impacting whether or not labs can go live or the amount of samples they can test. And this has really been compacted by the limited number of EUAs that have been awarded by the FDA. While they're ramping up this process, the supply just can't seem to catch up with the demand. And then new vendors are popping up left and right, but they haven't been verified. So it seems to be a bit of a black box right now. So you're not really sure if you're ever going to get the supplies you ordered. So shoring up the existing supply chain is really a key factor in continuing the growth of testing. Next, it's really virtually impossible to get a test if you're asymptomatic. You can't readily go to your physician's office or a testing site and just ask for a test. You have to be exhibiting symptoms, or at least you have to be claiming to be exhibiting them. The best option right now for asymptomatic patients is to pay $120 out of pocket for a direct-to-consumer test, and that's only offered by a few vendors right now. This model just isn't going to be able to handle the total volume of mass asymptomatic patients, but right now it is the best option. Total market capacity is just inadequate to meet the demand of regular testing. If we're going to regularly test our entire workforce, which is about 155 million people, we don't have this capacity to test them right now. This is something that John's going to speak to a little bit more later on, but as more equipment and more assays come online, we expect this to trend down, but again, we're far away from getting there. I don't think that payment and pricing really gets enough attention right now in the media, but it's really a huge factor for labs deciding whether or not they're going to bring this test online. When pricing first came out for COVID-19 for the PCR test, it was around $50, but the unit economics is just $30 for the test, and that doesn't even include the logistics costs. So labs are pretty much being asked to take a loss, to get these tests online, and especially in a time of uncertainty, not really knowing when they're going to be back up and running full labs right now. So subsequently, this has been bumped up to $100 for this high-throughput PCR test. And then we just found out last week that antibody testing was going to be reimbursed for $45 by CMS, but we still haven't seen any numbers from private payers. So labs still are left with a lot of uncertainty right now with how their economics are going to be and whether they're capable of bringing this online. Additionally, we have a decentralized and fragmented network of laboratories. So a lot of practices, a lot of physicians' offices tend to just partner with a single lab, which really presents unnecessary risk. So there's no real backups and turnaround time gets longer. So when they do get backed up, they don't have a system really to push these overflow samples seamlessly to another lab. So it really actually hurts the physician or the hospital provider not getting those results timely. We've heard about these 2 to 3 week lag times in getting results, which is just unacceptable for this type of testing. Additionally, we have the regulatory hurdles due to CLIA and state regulations that we should mention. Most of these tests being performed, even the lateral flow cassettes that that you're seeing being pushed out, require labs to be moderate or high complexity. This is really just creating additional layers of paperwork and requirements from the lab. So they have to be, which have to be, again, reviewed and approved by CLIA. And as far as state regulations, we don't need to look further past New York. They're one of the toughest states to get regulated in. And not only that, but it's also impossible to get really licensed to receive samples from out-of-state labs for New York samples. So these backlogs that they've experienced, they can't push them to out-of-state labs because of the regulations. So with that being said, we actually do have a few proposed solutions. So first, we suggest building a network of labs. This is going to allow you to load balance your sample volume. So think about it, it's monitoring incoming samples and your supply shipments, as well as pushing online orders. This can give labs valuable insight to expected sample volumes and supply chain concerns. And then sharing this information within the network can actually help you load balance the sample volume. So then we can also provide spillover testing protocols where we can have labs sending samples to other labs when we have issues. Additionally, there's a lot of lab equipment out there that's installed in the country that's just not being utilized for testing right now. And it's a matter of really helping those labs understand what's needed to get them up and running. So can we help them procure the testing consumables required? Can we get them validated quickly? And then we can help them potentially understand the economics to make sure that they can bring this test online, and then at a minimum at least recoup back that money. Everyone, especially in our industry and the laboratory industry, wants to be able to help, but it's tough to make those calls right now when you don't really understand what needs to be done. And that's something we can potentially help you do. And then we're going to talk a lot about this, which is shifting and centralizing monitoring responsibilities to employers. So we just got to be able to offer more asymptomatic testing. It's just not being offered enough. And it doesn't really make sense to scale up the direct-to-consumer model because of the logistics alone. It's going to be just too pricey. Places of work is really the only area where enough people populate to do this type of testing. So providing flat rate options to employers on a per employee basis can go into conjunction with contact tracing as a suggestion that we're thinking. It might be easier to get someone to go to get a test at their work site versus asking them to stand in line with a bunch of symptomatic patients waiting for a test. Lastly, we really need to centralize the data with contact tracing. So offering a single integrated lab network would allow for all reports to be kept in one software solution. This would ensure integrity of the data set and can help us limit potential gaps in contact tracing. So I do want to talk a little bit about the testing and the science behind all of this. So when John explains, kind of like our thoughts down the road, it kind of makes a little more sense. So I really loved this detection of COVID-19. It's one of my favorite charts that was found in a JAMA article. I think it does a really great job at distinguishing how PCR and antibody tests differ in relation to the time of symptom onset. So the solid lines that you're seeing are representing a different sample source, while the dotted lines are the antibody tests. So if you're going to look over here at the far left-hand side of the chart, this is really the pre-symptomatic time frame. So the virus might be present but undetectable. About 5 to 8 days prior to the onset of symptoms, the viral load begins to increase and then just peaks right here before the first week of symptoms. So this is when we're going to be able to detect the test via PCR. So we're actually detecting live virus via PCR. And then it kind of goes down after about 20 days where we're unable to detect live virus anymore via PCR. But that's when the antibodies ramp up. About 10 days is when your body starts producing antibodies. And then we start really seeing antibodies be present after that, about 20, within the next 20 days. And then actually for months later, we can actually potentially see the IgG antibodies present. So we're really going to be looking at this PCR to be the active infection guideline. PCR testing. So let's talk a little bit more about active infection testing in general. So, I'm sure you've heard a lot about this, but I just kind of go review it a little bit. So this is really molecular testing, and for the sake of COVID testing, we're actually looking for active virus in a patient's RNA using real-time reverse transcriptase polymerase chain reaction. That is a tongue twister, so I will just call it RT-PCR for everyone listening moving forward. But what we're doing is we're extracting and isolating and purifying RNA from either a nasopharyngeal or an oropharyngeal swab. We've also had saliva as an emerging sample type that just came out from a team in Rutgers. We'll talk about that a little bit later. But once this is purified, it's been reverse transcribed and to complementary DNA, and then we amplify it and detect it using our PCR instrumentation. We're typically going to detect the active virus within the first 20 days of symptoms onset. And as we mentioned earlier on, these nasal swabs have actually been While they're ideal for the testing, there's also been a shortage. So this has also been a problem with our bottleneck. This is really the gold standard in testing right now because it is monitoring active infection, and it's very sensitive and specific to the test and what we're looking for. With that being said, we also, the antibody test has been a popular buzz phrase lately. I think everyone's heard of that. That's really monitoring historic infection testing. So it's not looking for active virus, but rather it's detecting your immune system's response to the active virus through antibodies. So these are really serological tests. Usually we're doing an immunoassay, whether that's ELISA or these lateral flow kits that you're seeing. The sample type is usually whole blood, which is like the finger prick, or serum or plasma, which can be through venipuncture. But we're particularly looking for the immunoglobulins IgM or IgG. So the IgM is usually the first antibody produced by the immune system when a virus attacks. Its positive result indicates that you might have been infected or that you're starting to respond to a virus. So you actually might still be infected if you detect IgM. We're typically more seeing people being positive for the IgG, and it develops usually in patients within 7 to 10 days after symptoms begin. And it remains long after the infection's passed. So that can indicate that you've been positive in the past. There's still a lot of debate around this antibody test, and we know patients that have COVID will produce antibodies, but we're still curious if they have immunity. This question is really going to be important for understanding who can safely go back to work, as well as for understanding how long the worst impact of the pandemic are likely to last. Because the virus is so new, we're still not really sure of the question, but right now scientists are saying that the COVID-19 is acting like a lot of the other coronaviruses out there. So that means that the human body is probably going to retain memory of the virus for at least a few years and should hopefully protect from reinfection. Right now, there's no scholarly articles that have suggested that reinfection can occur right now. That's what I was reading last night. So I've mentioned the FDA'S emergency use authorizations before, so the FDA'S EUAs. And I just kind of want to touch on that again and briefly highlight what they are. It's really a designation given by the FDA to tests that have undergone an expedited, more limited approval process. So basically what they're saying is that no other alternatives are available that have met the normal protocols, but we've evaluated your test and we believe that the known potential benefit of the product outweighs any risk. So it does put the burden on the manufacturer to conduct their own internal validations, and then they have to submit all their information to the FDA. But it does waive some of the current good manufacturing practice requirements for the manufacturer. I feel like the real benefit, in my opinion, is given to the labs as well as because it does reduce a lot of the cumbersome and time-consuming studies typically required to bring a test online. Now they really only need to perform a straightforward validation. Without an EUA, though, the lab does have to perform, the test is considered lab-developed test. It does require high complexity testing, which we're going to talk about in the next slide. But just a brief overview of the tests that have been currently approved for EUA. Molecular tests, typically the nasal swab. It is looking for that RNA genetic sequence in active infection. There's plenty of EUAs out there for molecular testing. The advantage is this is really the gold standard for monitoring active infection right now. The downside is it's costly and it's specialized. You have to have that high complexity CLIA. You have to be a high complexity CLIA lab. Additionally, there is a new test that's out there. It's oral fluid. We do think that this is a lot of the future. Unfortunately, right now, there's only one EUA that's been available right now, and that's through Rutgers. The upside of this is ease of collection, and it really takes any risk out of those medical professionals that are collecting the specimens. The nasal swabs, they say, have actually make people sneeze, where the oral fluid, you can hand them this oral fluid, they spit into the oral fluid device, they can wipe it down and hand it back. There's no need, no contact there. The downside is, again, there's only one lab currently running that. So there is probably going to be a backflow until more labs get authorized to do this. The lateral flow finger prick test kits are looking for antibodies. We do have 3 EUAs that I've seen that are available right now. They are quick and easy to use, but the disadvantage is really the reliability of the sensitivity. So we're really kind of understanding if it's sensitive and accurate enough. In all of these devices, you still do need to go back and do a nasal swab after the fact to see if you have current active infection. The ELISA kit is also detecting antibodies, and I do think that the ELISA test is more scalable. Again, it is a specialized test. You do have to have specific CLIA license to be able to run this, but it does allow for high throughput. So I do think that this is kind of going to be a piece in the future for high throughput testing, and maybe ideal for contract tracing. Again, we're not really sure though what it's going to mean and what we're going to do with this data moving forward. Another test I just want to touch on real quick is the antigen test. It was just brought up by Quiddle in early May, and so it's pretty exciting that they can now do antigen tests. It's actually looking for the active infection for the viral protein. So it's going to be cheaper than that molecular DNA test long term, but there are concerns a little bit about the accuracy and potential for false negatives. So you might actually truly be positive and it's going to show be a negative result. Initial studies actually came out suggesting that 1 in 5 of the positive molecular tests are negative on the antigen test. So we're not really sure if this, where this is going to fit in, but we do see this helping with throughput, and it is pretty quick. So with that, I'm going to hand it, I'm going to talk about CLIA complexity real quick before we hand it back over to John. So just we want to acknowledge the CLIA complexities because this has been a real point of confusion for a lot of people. And so there are 3 levels set by the FDA when it comes to testing: waived, moderate, and high complexity. And the complexity really determines which lab can run the test, and it impacts, the parameters around the validation, the quality control standards, and actually going down to the technologists and the staffing, and who can oversee the test as a lab director. So this is a lot of actually what we do in our business. We advise on what's required for the type of lab you're building based on CLIA guidelines, state guidelines, and other accrediting bodies that oversee your lab operations. Understanding these requirements is even more critical now, as there's so many new tests coming to market, and you really need to understand who actually has authority to run them. So everyone thinks that they can run these lateral flow serology antibody tests, but they actually are considered moderate or high complexity. Those that are granted EUA status are moderate. Those that don't have EUA status, you have to create a lab developed test, and you have to be a high complexity lab to be able to do these tests. The ID Now molecular test by Abbott is considered a wave test, as is that antigen test that I mentioned earlier. Ironically, the ID Now test had some negative press last week. So that's not exactly great, but it is considered one of the wave tests that can be put in a physician's office if you have your CLIA wave license. And then the PCR molecular test, the complexity can go from moderate to high, and it's really dependent on, how it was assigned. And it's, the moderate or specific test kits on specific instrumentation might be moderate. But if there's anything that you waiver outside of that, whether it's the collection device or your storage, that takes it out of the EUA and then brings it now to a high complexity, or if you run on a different piece of instrumentation. So there is things that you need to be aware of if you are going to try to run these tests, and you really do need to follow the EUA protocols. So now I'm going to hand it back to John to talk about the COVID-19 laboratory startup costs.
Yes, thank you, Kara. We covered a lot there. If you guys did not fully understand the depths of the science there, that's fine. That's what we're here for. So if we can help, let us know. A couple of housekeeping items that I didn't hit on up front, and I'll just put out a link to us as well. If you wanted to hear more about anything that Kara mentioned, we're happy to connect you with our scientists to go deeper on that. But there's a chat and a QA function. Some of you guys have found it. Feel free to drop questions in there. I see a few questions coming through. I think some of those are going to be answered on the second half of this presentation. I'll go through now. But we will get to everything that's there, hopefully, if we have enough time. I imagine we will. This will be available, a recording, and a link to this recording will be sent out to everybody that registered. So don't worry if you hear something, you miss it, you didn't jot it down, we'll get you a recording so you can follow up later. I'm going to get into the business side of this a little bit, and just what would it mean if you guys wanted to maybe start your own lab, if you're an employer and you have 100 employees or 500 employees or 1,000 employees, what would it look like to set up a lab to start testing? So this slide that's on here now is showing for the building of a lab. The most important numbers on there are probably that 300,000 number right here that you see. Let's see if it'll allow me to draw on the screen. It doesn't look like it will. But the 300,000 is the total cost for setting up a lab. That's going to include some build out and upfit of the physical space itself, an extraction platform, as well as a thermocycler that has some automation included with it. That's going to be able to meet all of the different employee or testing thresholds, the 1,000, 5,000, 10,000 a month numbers with that setup. There are cheaper setups that could do less. I'd say our cheapest PCR solution can do about 25 samples per day, and you're probably looking at around $60,000 to get that installed and validated for COVID testing. So, that'd be refurbished equipment. You're doing it really on a shoestring budget. That's about the cheapest you're going to do it. And that's putting it into an existing lab. If you don't have anything, there's probably some more SOPs and things that are required. You're maybe closer to $100,000. But for a more robust system that's going to be able to put out the numbers that we've indicated here in terms of the number of people that you're testing each month, you're going to probably spend about $300,000. This is using new instrumentation, and it also includes antibody testing as well, right? So this quote shows you, and we don't sell instruments or anything. This is just us giving you some back of the napkin math and numbers to crunch in case this is something that you were interested in doing. Most important things to note here, if you were to look at the cost of operating for 6 months plus the cost of the upfit, you'll see that it's going to cost you about $858,900, so a little under $900,000 to run the lab for 6 months. You do start to get cheaper with time, and so your cost per test is going to get lower and lower the more that you do it. But you're going to start off in probably the $70 to $100 range if you were to do that in-house, and then you can get that number way down. We're going to talk about some strategies to get that way down a little bit later in the presentation. And so those are the numbers for building out a lab, just so you have them. Some of the other side of the equation is the reimbursement. This is assuming that you're billing a commercial payer or federal insurance. We're going to pull the federal numbers mostly and rely on those because the commercial varies greatly between Blue Cross United and on what your contract states. But the molecular swab PCR test, between 50 and 100 is the reimbursement you're going to see, and the cost to run that consumable-wise is between $20 and $30 per test. The difference between the 50 and 100, because that is a big range, depends on your throughput. So if you're running the test on a platform that does less than 200 samples per day, you're going to be reimbursed with a different billing code that's going to pay you, I think it's $51. If you are at a high throughput, greater than 200 samples per day, you're going to be able to be reimbursed at the $100 amount. The antibody testing around $19, and those lateral flow kits are going to range from $8 to $15. When the market's not crazy and the supply chain is normal, probably closer to that 8, maybe even a little lower, but it's not uncommon to pay 15 right now because there's some shortages out there, and there's just a lot of bad ones, right? So when those lateral flow kits got released, the FDA for the first time allowed groups to just go ahead and go right to market and start offering those and selling them without going through the EUA or any FDA approval process and let them self-validate. That turned out to be kind of a bad idea. I saw some numbers showing about a 48% false negative rate on some of those that were on the market. They have stepped in and asked for those to be brought through the traditional or somewhat traditional workflow where they will apply for an EUA and show their validation data. So the kits out there, you want to be careful about what you're using, but you're probably going to spend between 8 and 15 and get reimbursed around 19. There is a reimbursement code for antibody, which is closer to 45 now from the federal government, from CMS, that was released recently. I'm not sure that it gets down to the level of distinguishing between the rapid lateral flow kit and the ELISA. I haven't seen any verbiage that breaks those two out. So I think even on the rapid flow kit, you might get 45, but that's something that we're tracking right now. The antigen test, which is the newer test, seems pretty promising. The price point on it is $2 to $3, which is great. Really good positive rates on that. If you get a positive, it's going to be positive. False negative rate really high though, so the sensitivity is not quite there. Got about a 20% false negative rate. We don't have numbers for reimbursement, but we think it's probably going to come in around $19 for reimbursement for that. These are some of the headlines. I'm sure you guys are bombarded daily with COVID headlines, and you start to get kind of desensitized to it, but these do have impact on your decision, right? So as we look at getting back to work, what does that mean for an employer? Will an employer be held liable if they bring people back and contagious individuals get into the workplace and start spreading infection? If somebody dies as a result of that and the employer didn't take the necessary steps, could they be held responsible for that? These are questions we don't have a whole lot of precedent on, but they're things that you probably want to be thinking about. We've seen already several outbreaks. Meatpacking plants were a good example where individuals came in and, there was massive outbreaks as a result of that because it was close quarters and there was no testing being done on the front end to see if people were contagious before they came back to work. Some other headlines that are kind of neat in here: Amazon is going to test all COVID-19 or all employees for COVID-19. It looks like they are going to invest $1 billion with a B into COVID testing in the year 2020, according to an article with an Amazon executive. It looks like they're trying to validate a saliva antigen test that would be self-collected by the employee at a little station where they'd walk up, swab themselves, put it in there, get the green light, and then go into the work site. Really cool, interesting. If they can pull it off, we'll see. They're throwing a lot of money against it. So with enough funds, usually you can solve most problems. And we do think that there are some really interesting possibilities for getting mass testing available at a cheap price. We've seen this happen in Wuhan. One of these headlines shows, for 6.57 million, people were able to be tested in 10 days. Numbers even gotten better in some of the more recent articles I've seen. So we'll get into how that's possible, because if any of you have looked at this, it's hard to imagine how you could do that much testing that quickly. Some of the different parts of this is geared more towards thinking of this as an employer. So whether you're a lab or an employer group, if you're a lab, you're probably going to service employers. There needs to be three gears to the wheel where they need to do the testing, but that's just one part. Also need to have the social distancing, right? And so that might look like signage in the workplace. That might be, certain spaces are not available for group gathering. One person in a bathroom at a time, having directional hallways. Ford, I know, has bracelets now where if employees are within 6 feet of each other, they beep. That's really extreme. I don't know if many employers are going to go to that measure, but you do want to at least take action to show that you've put up signage, you've given instructions to your employees on how to remain safe. You've provided hand sanitizer and disinfectant and everything you can to be able to prevent infection from spreading. We do recommend that testing happens on the front end of that. And so your individual employees would make an appointment to get tested and not come back to work until they had a negative. I think ongoing testing is going to be needed, and that would be the PCR test. And I also think contact tracing, right? So if you do get a positive, what do you do now? You need to probably test everybody else in that work area that was in contact with that individual. You're going to need some contact tracing software, or you can maybe do it on a spreadsheet if your employee headcount's not too big. Salesforce.com has come out with some of that and built it into their CRM, which is kind of neat. But you'll need to think through your SOP. If there was a positive, what's next, right? Because you don't want to have to try to write that or figure out that plan in the heat of the moment. So I would recommend, before you bring everybody back to work, if you haven't already, coming up with what your plan is if you do get a positive and how you're going to respond to that. I think that's going to give people security. I think all of this, there's a lot of what we're battling here is fear too, not just the virus, but the fear too. And so the more structure, instruction, systems that you can put in place to give comfort to your employees, I think is a good move. And then also that's going to reduce your risk a little bit, right? So if you're able to point back that you took your best effort at trying to prevent infection from occurring, I think that will go a long way. I'm not a lawyer, but I do think that the difference of bringing your employees back and having widespread infection occur and not doing anything versus doing some testing and doing some of the other social distancing measures that we talked about is going to be looked at very differently, right? Because I don't think anyone can expect an employer to guarantee that somebody would not get infected, but you can take some steps to really limit that and mitigate that risk. It's going to be for your own benefit as well as an employer, because an outbreak is going to be costly in a few different ways. It's going to hurt your attendance. If you have a health plan that you're funding, it's going to be expensive on that side. And just having your other employees get infected as well is really going to hurt productivity, right? If that spreads inside in the workplace. So I think, having a plan is going to reduce risk. It's also going to give some confidence to your employees to come back to work and not be working in a state of fear, and just know that you care about them. So some other issues to consider. Can an employer mandate testing? We were waiting on this for a while just to know what are the rules. Can you tell an employee that they have to get a medical test, that seems to maybe step over some bounds. The EEOC has said that while COVID-19 remains a direct threat, in quotes, employers can go ahead and require testing and make that mandatory for returning to the workplace, right? Because they're a direct threat to their fellow peers and employees. So yes, you can do that. What do you have to do with the medical records, right? And is a physician needed to order the test? There's some other questions. So the medical records part, you need to consider privacy. You need to look at ADA rules. You can't discriminate. You want to be really careful on using names that might come into play when you're doing the contact tracing. You don't want to say, hey, Sally's positive for COVID, so we need the rest of you guys to get tested. You might have just breached some privacy on your employee side, so you want to be careful about how you do that and be discreet. If you do keep medical records, this would be especially true if you have a lab on site. So as an employer, you decide to bring a lab on site. Now you're going to fall under HIPAA requirements, right? So you need to make sure that patient privacy is kept intact. We would recommend a physician order be put behind every lab test. Still some gray out there on that. I haven't seen anybody doing the testing yet without physician order. I wouldn't recommend being the first in the pool on that one. There are states that allow you to order tests on your own. High-risk tests in particular typically do not make good direct-to-consumer tests. Reporting results gets a little bit tricky there. So we would recommend putting a physician order behind every lab test. That's something that we provide. You don't have to use us. There's other companies that do it, but I think we do it well and pretty affordably. Our price ranges from between $5 per test to down to $1 per test, depending on volume. And so not a whole lot more to get that test done. Just make sure that you have a physician standing behind that. So that would be our recommendation on that. This is our program. So we do have two different options for our WorkSafe employer solution. One of those is to put a lab on site, and that would make the most sense for groups that have large employee counts and are looking to do frequent testing. You'll be able to get the cost per test down by doing it yourself over time, and there will be a return on investment eventually on that. However, we know that that's probably a big ask for most employers. So another option is our WorkSafe lab network. That network, we would plug you into a load balanced network of COVID testing labs with the intent of trying to keep COVID samples off of planes, keep them as close to where the collection happened as possible. We are able to set that up, all the labs on the software up on a load balanced network so that we have rules routing the samples based on capacity. We think that's going to be a big part of the solution for this as testing becomes more mainstream. We're offering that on a per employee per month basis, $100 per employee per month. You do get multiple DNA tests, 2 tests, PCR tests per month per employee, as well as an antibody test every other month there. And that's more for tracking of infection in the workplace to just make sure that communities are not seeing that in the asymptomatic role and they're not getting caught by the PCR test. But that's how we would recommend going about it. We do have that program available. If you guys want to hear more about that, we're happy to talk to you about it. I'll go ahead and I'll put a slide out on the screen so you can respond to that. If it's something that interests you, we'll follow up with a call to talk to you a little bit more about it. The other thing that I think we've done, and we're also able to talk to you about the on-site program. If you guys want us to build you a lab, we're happy to do that too. We can go through what it would look like and get a little bit deeper on the pro forma there. The other thing that we feel like is really intriguing and is going to be part of this solution is the sample pooling, right? So sample pooling, hopefully follow me here on this graph. You'll see the power of it. You can take, as an example, you have 100 people. We break those into groups of 20 patients. So there'd be 5 groups of 20 patients. We mix the sample of those 20 patients into one, and then we test that pooled sample. If it tests positive, then we're going to go ahead and we're going to test all 20 individuals in that pool. We've set aside a part of the sample ahead of time, so there's no going back for another sample collection needed. We can test those 20 individuals to see who was positive inside of that. Right now, we're running in the asymptomatic population less than a 1% positive rate. So this really unlocks a lot of increased throughput capability, as well as reduces the cost quite a bit, right? So by pooling, we're able to see about a 400% increase in throughput, and we're able to take the cost per test way down, probably to about $6 a test. I don't know if anybody's been able to really touch that. I haven't heard of anyone else doing that for the PCR test. So we think that's going to be part of the solution and make it possible to test all your employees and to test them regularly. So this flow chart here, you'll see on the left side, the group of 20 people, we go ahead and put those in 5 different batches. So there'll be 5 tests run. We'll look at the results. If one of those is positive, the 20 patients that were involved in that one sample will be broken out into 20 individual tests. And if they get a positive result, we'd know who that is. If they get negative results on the whole group, then they would just go through it. We wouldn't need any more tests. So you can imagine the consumable cost savings and the throughput benefit to that. That's the basics on what we're doing. I'm going to throw another poll out there for you guys. I'm kind of curious on what you think in terms of a reasonable price point. The market's not really established, especially on cash pay, on what should people be paying for this test. I think that's a key to unlocking. It has to be affordable, but it also has to be at a price point where labs can make money in order to offer it. So once somebody figures out where that magic number is, I think that we'll see the rest of the market follow. We'll go ahead and we'll open it up to Q&A at this point. So if you guys have questions, you can go ahead and drop those in the chat or in the Q&A. You can always follow up with us later. I'll give you one more opportunity to reach out to us if you wanted to schedule a time to talk about anything that was covered. We're happy to chat with you on that a little bit more. But let's go ahead and flip over to the chat and see if there's any questions that we should address. I see some of these have already been answered. Any update on state regulation to receive samples from out of state? Yes, the same as it's always been, right? So there's 6 states, I believe, that require your lab to be licensed to receive samples from them. Off the top of my head, I believe it is Pennsylvania, Maryland, Massachusetts. Florida used to be, but got rid of it last year. New Jersey, if you're doing the collection, you have a collection center in New Jersey, you need to be licensed. Otherwise, if it's coming from a clinic or the employer was collecting the sample directly, you would not need one. New York, of course, California, Nevada, I believe is similar to New Jersey, where you also only need to get licensed if you have a sample collection center. We do have pricing on Lighthouse's website under our application processing area for every state and what we charge for that. So if your lab is not licensed to receive samples in a state and you'd like to, those prices range from, I believe, about $1,500 to maybe about $5,500 for the most expensive to get your lab accredited. There are other things that kick in. If you want to be licensed in the state of New York, you need a New York licensed lab director that holds a certificate of qualification in the subspecialty of the testing that you're offering. And that person has to be on site a minimum of 20 hours a week. And your lab director is only allowed to direct 2 labs total. So that usually makes it too cost prohibitive for most labs to get licensed inside the state of New York. If you already have a full-time lab director, maybe it makes sense. We can help with getting your existing lab director licensed with a certificate of qualification from New York, but can take anywhere. I don't know why it takes this long on average, but we've seen it be probably 9 to 15 months on average that those applications get processed. A lot of it is on the lab side too, and on the lab director side, because there's a lot of information requested and references going back to when they graduated from school 20 years ago sometimes. And so it's a laborious process, but it can be done. So hopefully that answers your question, Sam. Once employers have tested all employees, how often do you recommend they retest? I don't know that I want to speak as an authority on this, as I'm not a clinician. I do think that our program, we felt like a 2-week cadence was appropriate, that we would test every patient every 2 weeks. There's still some holes there, right? You could test them, and the day after they're tested, they could have left that testing site, been exposed, and a few days later be infected and contagious, and you would not catch that before the next 2 weeks. So there's no foolproof system, unless you're going to be testing them every day. I don't think anybody's going to be able to get the price down to make that reasonable. I think a 2-week cadence is probably pretty appropriate. So that's my John Harrell's opinion. But obviously there's people that are smarter than I am that went to school for this that you might want to speak with before you made a decision. Michael, this will be available afterwards. We will make a recording available. JD, yes, we are plugged in. We have an agreement struck with Acumen to utilize their network capacity, so that is available. Joe Ben, is there a limit on the reimbursement of frequent testing? I don't think I've seen that yet. I know in some areas of clinical lab testing, that's obviously the case. Like if you're doing drug testing, therapeutic drug monitoring and drug testing, you are limited on the amount of times you can test and bill for it and get reimbursed. I have not seen a limit put out there yet on COVID testing. I would not be shocked if that eventually happened, but I haven't seen that happen yet. If you're talking cash pay, obviously it's a whole different game. But if you're looking to be reimbursed by the federal government, there typically is some rules. I would think that if it was deemed to be not medically necessary or to be testing that was done just for the sake of collecting reimbursement, not be responsible, I think you'd be liable for clawback. So no matter what you do, you need to make sure that it's all done through the lens of responsible testing. And the physician that's ordering that would also have responsibility to make sure that they are carrying out their responsibilities correctly. And so I would defer to them, but I would think, if you wanted to start testing people multiple times a day, that might be over the top. I think once a week, I could see that being justified. For high throughput labs, doing 200 plus COVID tests a day, can you bill at a different rate than the $100 Medicare? Yeah, that is the $100 number. And so you've seen that there are filters even for these high throughput labs. They're only getting 50 from commercial insurance. That's probably true. The commercial payers get to write their own rules, right? So you go into contract with Blue Cross, United, and based on the contract you've struck are the rules for your lab, right? So you might be reimbursed at 50% of Medicare. That's not uncommon. I see contracts as low as 25% of Medicare. So I can't speak to what your individual contract with a commercial payer would be, John. On the Medicare side, I believe it's $51 if you're considered moderate or low throughput, and it's $100 if you're doing more than 200 samples per day. So hopefully that answers your question. So Kara, looks like you answered the question with the billing code, the 83628, the 4523 number for antibody testing. Hopefully that's helpful.
And that's
Rihanna.
John, just that's specifically for the lateral flow kit, for the one-step kit.
Okay, so rapid kit at 45, good margin there. You're probably $15 or less to run that test and get reimbursed 45. Key thing to know about the antibody test, it's not diagnostic. A negative is not a negative, right? And so just because somebody doesn't have the antibody does not mean they're not currently infectious. So I would not recommend it as a screening tool on the upfront side, right? So it is cheaper, it is easier to administer, but think of it this way, that if you have your employees come in and one of them, is recently infected and is actively contagious, they're probably going to test negative on the antibody test. So not a good use for that upfront screening. It's more for use for that, tracking the spread of an infection and contact tracing. And so just make sure that you're using that appropriately, but it is not a bad reimbursement. How can I get the Abbott ID Now instrument and test kit? I know that there was absolutely a shortage of those, Faye. Hard to get your hands on one. Even the groups that I know that were able to get an Abbott ID Now were not able to get some of the consumables needed to run it, and you have to use the stated consumable kits in order to fall under the EUA and not be an LDT. The other thing to consider is the press on that is really bad. It's being researched right now, but I saw over a 40% false negative rate with the Abbott ID Now, so a lot of people are pivoting away from that. So something to consider as you're looking at the instrument you're going to use. Amanda wants to know if we purchase a serology COVID kit that does not have an EUA, we would need to perform the validation if we are selling these to other labs or hospitals, right? So yeah, there's two different types of EUA. This gets a little bit deep. It might be something we need to take offline, Amanda, but you have an EUA for your test, for your lab, and that would be your workflow specific. We can help with validating these serology rapid flow kits. We have positive and negative samples for COVID that we can supply as part of that. We'll supply an SOP as well as a validation plan, and then daily controls in order to daily test your kits. And as long as they're from the same batch, we can put together a plan so that you can offer those lateral flow kits and have them validated. If you're distributing, there's a whole different EUA for distribution of a medical device. And unless that's the game that you're in, I'd recommend staying away from it, right? You don't want to distribute non-FDA approved instruments for medical use. I would leave that up to the other distributors, and then any ones that you do have, you would need to validate them before you use them. So hopefully answers that question. Do you see a high demand for PhD lab directors as you're installing COVID labs? So we have seen an uptick. We supply the medical lab directors, they're either PhDs or MDs, to 150 high complexity and moderate complexity CLIA labs around the country right now. I think we do more of that than anyone, so are able to probably tell you what the market looks like. We have seen a little bit of a fall off among physician office clinics that are non-COVID testing, some of them even closing because the patient flow has been so hurt by this crisis that we don't see a lot of testing happening inside those POLs. But that has been picked up by labs that are doing COVID testing. We are seeing a big uptick in moderate and wave labs that are now getting kicked up in terms of complexity to either moderate or high, and they need a new director as a result of that. If you are a director and want to send us your resume, we'd love to keep you on file because we do have those opportunities. Every week we fill multiple of those, and so we like to keep an eye on who's available and who's got spots on their licenses. So hopefully that helps. Any other questions? I don't know if I didn't look under Q&A.
There was 200 Q&A, John.
Sarah?
Yeah, there was 200
Okay.
Q&A, or at least.
Let's see. They already answered.
Oh, they were already answered. Yes, they can.
Yep. What is the level of
added one more.
Mm-hmm.
Perfect. What is the level of confinement required for a lab to do COVID testing? I'm not sure if I completely understand that. I think it may be in reference to like the biosafety level. And so if that's what you're referring to, it's a BSL-2 lab, I believe. Kara, I don't know if you know that better than I do, but I believe it's the same complexity as your typical testing lab, so there's no increase there. I know there are higher levels for biosafety if you're dealing with anthrax and some other things, but this does not push you into that. We would recommend that any of the extraction amplification that's being done for COVID testing be done on a biosafety cabinet that has some protection built in to prevent cross-contamination and prevent the tech that's doing the work from being put in a dangerous position by working on that sample. So you can either do that through working in separate rooms or through using a biosafety cabinet. Under employer required lab test, who will receive the result? How can they get referral from provider? Right, so I think I answered that. Hopefully we do have a physician network that we use that has physicians licensed in all 50 states that can be the authorized provider for the test and release the result. They're typically going to recommend that the lab that's performing the test deliver the result, especially a positive. And that can be a healthcare employee. There's no real designation that I know of, at least on a federal level or any state levels that I know of what the qualifications are of the individual that calls in the lab test order to the patient. But I would recommend it being someone that's fairly knowledgeable and able to direct that person to speak with their primary care physician, or maybe patch them through to a telemedicine physician for a consult if they are positive, just so they know what kind of treatment alternatives are out there and what they should do. Probably going to tell them to go stay at home. So until we have some better treatment options. Well, I think that that brings us pretty close to the end of the time here. So I'm going to go ahead and wrap up. I appreciate all of you guys attending. Feel free to reach out to us. Our contact information is on the screen if you have any additional questions. We'd love to talk to you about it and let us know if we can help. We can also help with staffing. If you do have a COVID lab and you need molecular scientists, we have over 200 of them ready to go that want to work in COVID testing labs that have PCR experience. We've been categorizing all of those in our database and just have them ready, locked and loaded. So let us know if we can help with that. Kara, anything else as a parting comment?
No, I think that, we're just really excited to work with this and to bring a lot more, COVID labs online. We really want to, like I think you said last time, we really want to improve testing, but we also want to reduce the fear of going back to work as well. So we think that this testing protocol and this WorkSafe program is a great idea, and we hope to hear from a lot of you.
Great. And then also handouts. Under the handouts tab, you'll see we have 2 different handouts, PDFs that you can click and download if you're interested. One of them covers our sample pooling initiative. If you have COVID testing in your lab and you would be interested in exploring sample pooling, let us know. We can help you guys get that validated. If you're interested in the WorkSafe program, either having us build you a lab or subscription model to test your employees, let us know there, and that handout's there as well. Well, thank you all very much. I appreciate it. Thank you for your time. I know it's precious, and I hope you'll attend one of our other Petri Dish webinars in the future. We'll talk about other topics. Thanks, everybody.